It is a great pleasure for me to be participating in this important Congress on osteology and mineral metabolism for your great country. It is too bad that I cannot join you in Chile. I have been to Chile several times, and I hope to be able to visit you again. This presentation is going to be on primary hyperparathyroidism. And in the next 40 minutes, I'm going to give you an update on this disease with regard to several very important elements. Let me start with the common definition of primary hyperparathyroidism. And you all know this is a very common endocrine disease characterized by excessive secretion of parathyroid hormone from one or more of the four parathyroid glands. In adults, typically, 80% of patients will have a single benign parathyroid adenoma. Classically, this disease is associated with hypercalcemia and elevated levels of parathyroid hormone. Sometimes the parathyroid hormone level is within the normal range, but for hypercalcemia, of course, that is not normal. There are three generational phenotypes of this disease. Before 1970, this was considered to be a disease of bones, stones, and bones. And on this slide, shown on the left, is the famous sea captain, Charles Martel. You can see how healthy he looks. And next to him is a photograph of himself just several years later. And you can see what potential primary hyperparathyroidism has to actually destroy the skeleton. On the right are x-rays of a patient I took care of many, many years ago. And you can see the skull shows the salt and pepper degranulation. The clavicle is missing its outer third radiologically. There is subperiosteal bone resorption of phalanges, and the pelvis of this lady is riddled with osteitis fibrosis cystica. Of course, we don't see that kind of primary hyperparathyroidism that much anymore. Rather, we see a disorder that is usually discovered in the context of a biochemical screening test, and thus patients do not appear to have symptoms of this disease. The typical table of biochemistries is shown here from one of our studies many years ago, but we typically see a serum calcium level that is slightly above the normal range. The parathyroid hormone level is about twice the upper limits of normal. You can see the 25-hydroxyvitamin D and the 125-dihydroxyvitamin D levels are low for the 25-hydroxyvitamin D and the upper range of normal for the active metabolite. When dual energy X-ray absorptiometry became widely used throughout the world, we were one of the first to show this very typical pattern of bone involvement in this disease. And what you see on this slide is the lumbar spine bone density that looks reasonably normal. The femoral neck bone density shows a reduction, and the distal third of the radius, which is the site of cortical bone, shows the greatest amount of involvement. And this typifies the potential of parathyroid hormone to be catabolic at cortical sites and not so much at trabecular sites. Obviously, the reason for this change in the presentation of primary hyperparathyroidism relates to the introduction and widespread use of biochemical screening. And this slide makes the point that from 1970 to about 1975, there was a very large increase in the incidence of primary hyperparathyroidism. And this dated the introduction of the screening test in the United States. And as you can see on this slide, virtually all of these patients being discovered were asymptomatic. And this led to a very important question that we are still asking, namely, who among these asymptomatic patients need surgery and who can do well without surgery. And to this end, there have been 4 international workshops on the management of primary hyperparathyroidism. Actually, at this time, we are conducting the 5th international workshop, and hopefully we will have revised guidelines by the end of this year. But the current guidelines are shown here. These are guidelines that would lead us to recommend parathyroid surgery. If the serum calcium is 1 milligram per deciliter above the upper limits of normal, we would consider that to be an important observation recommending surgery. If a patient has a bone density by T-score less than minus 2.5 at any of the 3 sites, in addition to which, if there is a vertebral fracture by X-ray or by vertebral fracture assessment, here again would be guidelines for surgery. The renal system also has guidelines, such as a reduction in the creatinine clearance to less than 60 cc's per minute, the visualization of a kidney stone by any of the imaging modalities you see here. In addition, patients who have marked hypercalciuria, namely greater than 400 milligrams per day, in addition to other urinary biochemical indices of increased stone risk, again, any of these would meet criteria for surgery. And finally, in younger individuals under the age of 50, they are at increased risk. Now, patients do not have to meet all of these criteria. One is sufficient. For those patients who do not meet criteria for surgery, we have a suggested schedule of maintenance, such as the measurement of the serum calcium on every year. We would recommend doing a DEXA test every 1 or 2 years, and further imaging if the situation were clinically indicated. We also recommend an estimated GFR or creatinine clearance annually, and again, imaging modalities if the situation is appropriate. Now, I mentioned these as guidelines. It's important to make the point that guidelines are not rules. They are not always followed. They're considered to be generally useful, and they're based upon the best available evidence. Sometimes the best available evidence is actually not that compelling. The other point to make is that patients can have parathyroid surgery even if they don't meet guidelines. And in addition, some patients who do meet guidelines will decide not to have parathyroid surgery. And even those who meet guidelines, sometimes because of medical contraindications, they will not have parathyroid surgery. Now, over the past several years, our group and many others throughout the world have investigated many aspects of this disease. We don't have time today to cover everything, but I will touch on the highlights. One of the highlights has to do with yet another form of primary hyperparathyroidism. We were one of the first groups to note that patients with high PTH levels, usually the calcium is elevated, but not always. And in fact, we studied and published on a number of groups of individuals whose serum calcium was actually normal, but whose parathyroid hormone level was consistently elevated. And very recently, the group of Richard E. Stell in the United Kingdom has published this paper in the Journal of Clinical Endocrinology and Metabolism. And on the left, you can see in the middle, the normal calcemic hyperparathyroid patients. On the right, the parathyroid group, the hypercalcemic group. And you can see that both of these parathyroid groups have levels of calcium that are a bit higher than the normal controls, but the normal calcemic individuals have normal serum calcium levels. And on the right, looking at parathyroid hormone, you can see that the normal calcemic group and the group with hypercalcemia have equivalently high levels of parathyroid hormone. Now, as endocrinologists, we know that a high PTH level with a normal calcium is not necessarily a primary disorder of the parathyroids. We have to recognize that there are many causes for a high PTH with a normal calcium. These situations that we call secondary hyperparathyroidism are listed here. We want to make sure patients are not vitamin D deficient. And for this discussion, we want our patients to have a 25 hydroxy vitamin D level that is greater than 30 nanograms per ml. We know that renal insufficiency less than estimated GFR of 60 ml per minute can be associated with a high PTH level. We know that thiazide diuretics and lithium can be associated with a high PTH level. Unusually, patients who have a primary renal leak disorder of hypercalciuria can have a high PTH level. Any gastrointestinal disease associated with malabsorption and other metabolic bone diseases such as Paget's disease. We also should note that the drug we use for osteoporosis, denosumab, can also be associated with a high PTH level. But we typically rule these situations out, and we're left with this condition that we now call normocalcemic primary hyperparathyroidism. This is a table that summarizes the prevalence of normocalcemic hyperparathyroidism, and I've outlined actually the papers that are generally consistent in terms of prevalence, somewhere between 0.1 and 0.6%, including the most recent paper that I just alluded to. There have been other papers that have indicated that the incidence may be higher, but this is not typically the case. From our study, we noted that many of these people with normocalcemic hyperparathyroidism had issues with regard to their mineral metabolism. 3/4 of them had low bone density, about 10% had fractures, about 5% had kidney stones. So this is really an interesting presentation of individuals who actually do have target organ involvement. Comparing normocalcemic hyperparathyroidism with hypercalcemic hyperparathyroidism, the group of Richard E. Stell recently published this, and I've again boxed the areas of interest, and they are not different from these two conditions, even though the normocalcemic group has a lower serum calcium level, and it is within the normal range. But as a group, these two parathyroid presentations show differences from the control population. And that is specifically with regard to the parathyroid hormone level, the serum calcium, the phosphorus, as well as maybe the 25 hydroxy vitamin D. Notice that urinary calcium excretion in the normal calcemic group is much lower, but not statistically lower than the group with hypercalcemic primary hyperparathyroidism. Again, as I alluded to, this normocalcemic group does have issues, and I've just highlighted the fact that a significant percentage of them have osteoporosis, and a significant percentage of these individuals, again, canvassing a lot of papers, will have evidence for kidney stones. So the interesting paradox here is that patients with normocalcemic hyperparathyroidism seem to be present with more issues than typical cohorts of hypercalcemic patients with mild hyperparathyroidism. And our group, as well as many others, would explain this by saying that this is probably selection bias, because we typically are referred these patients. But if you looked more broadly, you can certainly find this disease that doesn't involve the target organs to the same extent. The point being that they are not being discovered incidentally. The natural history of normal calcemic hyperparathyroidism, again, I've highlighted the percentage of individuals who develop hypercalcemia over the years, and they range from none to the most recent paper in which the 64% of individuals had intermittent hypercalcemia. So clearly, normal calcemic primary hyperparathyroidism is a clinical presentation, and there is a management approach that we have recommended. We would measure the parathyroid hormone and calcium levels on an annual basis, measure bone density every 1 or 2 years. In patients who become hypercalcemic, and about 20 to 25% of them will, we would follow the guidelines that we have already published. If those individuals do not develop hypercalcemia, but have developing worsening bone density or fracture, they may develop a kidney stone or nephrocalcinosis. Again, they would fit into the category in which we would recommend surgery. So again, there are 3 generational phenotypes of this disease, as I've described. And it doesn't mean that we don't see one or the other. It all depends on where we are in the world and whether or not we have a program of biochemical and densitometric screening, as well as whether or not we are a referral center. And so depending on where we are, we may see more of one than another. But the point being that there are 3 of these generational phenotypes. I think the symptomatic hyperparathyroidism is more likely to occur in countries where there's little or no biochemical screening. These countries also tend to have low vitamin D levels throughout the country. In asymptomatic hyperparathyroidism, it would be typically countries where we routinely screen the population with a serum calcium level. As I mentioned, normal calcemic would be those medical centers where metabolic bone diseases are a specialty and parathyroid hormone levels are routinely obtained, even in those with adjusted calcium concentrations that are normal. Let me move now on to skeletal assessment. By virtue of bone density, one might expect that there would be an increase in non-vertebral fractures because cortical bone is compromised typically in primary hyperparathyroidism. In the central skeleton, which is more trabecular bone, you might not expect to be seeing very much of a difference in the incidence. However, this observation made by Professor Sandeep Khosla at the Mayo Clinic about 20 years ago argues against that expectation. In his work, he showed that fractures were increased no matter whether they were vertebral fractures, distal forearm fractures, rib fractures, or any fractures. And this observation ran against the expectation that there'd be a differentiation with more non-vertebral fractures than vertebral fractures. And very recently, Lars Renmark from Denmark has published a systematic review of fractures in primary hyperparathyroidism. And I've highlighted the results of that study showing that the relative risk is increased for any fracture, for forearm fractures, as well as for vertebral fractures in patients with primary hyperparathyroidism. And this meta-analysis looked at 11 different papers, and as shown here, documenting them very clearly. There was not a significant increase in hip fractures, but there was a trend. So I think we can clearly make the point that fractures incidences are increased in hyperparathyroidism. In order to understand better why this is the case, since DEXA wasn't giving us the kinds of results that would be consistent with an overall increase in fracture risk, we took advantage of extreme CT and were able to visualize microstructure of the tibia and the radius non-invasively. And this is a depiction of a typical patient with hyperparathyroidism compared to controls. And you can see that there appears to be both cortical thinning, but also the trabecular compartment of bone seems to be compromised as well. Hansen from Denmark was the first to show that these trabecular indices in the radius, as well as trabecular indices in the tibia, are lower in hyperparathyroidism than in controls. Our study also showed, this is a complicated slide, but it doesn't matter that I point everything out, that red line is normality, and to the left or to the right are abnormal numbers. And you can see in the middle of the slide, again, trabecular indices are lower at both the radius and the tibia, as well as cortical indices. So our study also was consistent with reductions in trabecular and cortical indices in asymptomatic hyperparathyroidism. Now, not everybody has access to extreme CT, but we have much more ready access to the trabecular bone score. The trabecular bone score is a readily accessible method that can give information about skeletal microstructure. I think some of you may be familiar with the trabecular bone score. It is an imaging modality based on the DEXA image, and you can see the examples of A and B. The B is representing a very heterogeneous pattern, much more consistent with an osteoporotic picture, if you will. And using the trabecular bone score, we've been able to show that the typical patients with hyperparathyroidism have a degraded skeleton, typical of reduction in trabecular bone, compared to DEXA, where we don't see this very much. And if you look at the percentage of individuals who have normal trabecular bone score, it's a minority versus a majority of individuals who have normal trabecular bone by bone density. So clearly, trabecular bone score can help us to assess bone quality in primary hyperparathyroidism. I think we can conclude that using these advanced imaging modalities, that both cortical and trabecular compartments are compromised in primary hyperparathyroidism, and this is consistent with an increase in fracture risk. Based upon these newer observations, we are recommending, in addition to doing routine 3-site DEXA, that all patients with hyperparathyroidism have one of the following: either vertebral fracture assessment, trabecular bone score, or conventional vertebral x-rays. Let me move on to the renal assessment. Although the kidney is a target organ, and we are obviously concerned about kidney stones, you'll note here in a more recent study that kidney stones continue to be evident. Much less evident than earlier studies, but nevertheless, most studies will give an incidence of somewhere between 20 and 30% of kidney stones. And if you look at imaging modalities, you'll see even more. We know that renal compromise can lead to more skeletal disease. We know that hypercalciuria can be associated with an increased risk of kidney stone, particularly if there are other predictive risk factors in patients with hyperparathyroidism. As I just alluded to, if you take advantage of non-invasive imaging modalities such as X-ray, ultrasound, or CT, the incidence of kidney stones or nephrocalcinosis can be as high as 50%. And as I mentioned, and most recently from Claudio Marcocci's group in Pisa, Italy, kidney stones continue to be the most common complication of primary hyperparathyroidism. So with regard to the kidney system, we are recommending that all patients have a 24-hour urine for calcium and other stone risk factors, as well as some form of abdominal imaging. Let me now move on to some of the less classical features of primary hyperparathyroidism. And I like to dwell first on quality of life and then the cardiovascular system. We know that many patients with hyperparathyroidism have constitutional manifestations shown here. And although many of us are intrigued that there might be an etiological link to these nonspecific complaints, we are also aware that there are many disorders, including many endocrine disorders, in which these same complaints are offered by patients. So the lack of specificity has raised questions as whether or not these complaints are really related, in fact, to primary hyperparathyroidism. There have been a number of randomized controlled trials to look at whether or not parathyroidectomy would improve these so-called neuropsychiatric or cognitive symptoms. These studies were not consistent and did not really give us any clear answers. But much more recently, the group by Jens Boleslav in Norway has given us more insight. They studied over a 10-year period, almost 200 subjects with asymptomatic primary hyperparathyroidism. They were randomized 1-to-1 either to have parathyroid surgery or just have observation. 2 quality of life scales were used, the typical SF-36 scale and another one, that each of which was tested at baseline at 2, 5, and 10 years. It is a truth for most long-term studies that one would expect attrition, and about 1/3 of these patients were lost in the course of this study. It was done as an intention to treat analysis. And the points of the study are shown here. Those patients who had parathyroid surgery were cured biochemically. Those who were not treated with parathyroid surgery continued to show hypercalcemia and elevated levels of parathyroid hormone that remained where they were without any change. Interestingly, only one of the 8 SF-36 scales, vitality, was improved after parathyroid surgery. 7 of the 8 were not improved. And in the other quality of life scales, both the placebo group and the surgical group showed similar changes. So the conclusion of this very heroic 10-year study is that parathyroidectomy does not improve quality of life. It is also noteworthy that this study concluded that observation without surgery does not worsen quality of life. I think this paper helps to answer the point that we really cannot attribute these off-target features of primary hyperparathyroidism in terms of quality of life specifically to the disease. Now, we don't have time to go into the cardiovascular manifestations of primary hyperparathyroidism that have been well documented in symptomatic disease. The question has been, in asymptomatic primary hyperparathyroidism, are these features of cardiovascular function abnormal? And very simply put, we don't know. The data are very uncertain. If present, they're very subtle. And I think in asymptomatic hyperparathyroidism, we really cannot reach any definitive conclusions. So with regard to neurocognitive and the cardiovascular systems, the data are simply not strong to allow us to make decisions on surgical management. Now, a little bit more certain are data with respect to vitamin D. This is an old hypothesis that the clinical manifestations of primary hyperparathyroidism may be more severe in the presence of vitamin D deficiency. A study I did about 20 years ago was noteworthy in this regard. We compared our population in New York with a population in Beijing, China. And as you'll notice by these pie graphs, the patients from Beijing, China, virtually all of them were symptomatic of the disease, whereas in our population, only about 20%, as shown in the blue slice of this pie, were symptomatic. So we were dealing with two cohorts, one of which symptomatic and one of which was asymptomatic. And this table compares the two groups in terms of their biochemistries. And I'm going to quickly direct you to the 25-hydroxy vitamin D level. In the group from Beijing, the average level was only 8.8 nanograms per ml, while the group from New York had an average 25-hydroxy vitamin D of 21 nanograms per ml. Furthermore, if you looked at our population and divided it into those with levels of 25-hydroxy vitamin D that were less than 20 or greater than 20, you can see that the parathyroid hormone level was much higher in those who had levels of 25-hydroxy vitamin D that were less than 20 nanograms per ml. So I think this is good evidence to certainly document the recommendation that the 25-hydroxy vitamin D level in our patients should definitely be over 20 nanograms per ml. And some experts, and I would include myself among them, recommend levels over 30 nanograms per ml. For normal calcemic primary hyperparathyroidism, some experts actually recommend that we have levels over 40 nanograms per ml. And that is because some people think that the normal calcemic variant may be related, at least in part, to some element of vitamin D resistance. In terms of calcium, we recommend the usual guidelines. Nutritionally, patients should be getting approximately 1,000 milligrams of calcium. We definitely do not recommend low calcium diets in patients with primary hyperparathyroidism. Those individuals who meet surgical guidelines and are going to have surgery are most of the time going to have preoperative localization. And I list here the various preoperative localization approaches. There's a more recent one that has been developed, and we use it at Columbia quite often, and that is four-dimensional CT. But it kind of depends where you are. Ultrasound can be helpful, CT, sestamibi with SPECT imaging, there's PET imaging. There are many different approaches, but the point is that as the field has moved away from the more extensive operation, these preoperative localization approaches can be extremely helpful. But much more helpful is finding the parathyroid surgeon. And I will make the point 3 times that a person should be experienced with an outstanding track record. I will say it again, that surgeon should be experienced with an outstanding track record. And I will say it again, because it's so important. You want to get a real expert in parathyroid surgery to operate on your patients. Dr. John Dotman said many years ago, the most important preoperative localization challenge in hyperparathyroidism is to locate the parathyroid surgeon. There are several operative approaches. There is the minimally invasive parathyroidectomy with intraoperative measurement of parathyroid hormone. For this approach, you must have identified the parathyroid gland preoperatively. Measurement of parathyroid hormone at baseline, 2 minutes, 5 minutes, and 10 minutes after removal of the parathyroid adenoma will show, if successful, a reduction in PTH2 by more than 50% into the normal range by 10 minutes. If that doesn't occur, the operation is then converted to a more complete full exploration. There are some surgeons who will subscribe to a full exploration on both sides of the neck. And again, this is a matter of experience and some controversy. After successful parathyroidectomy, all of these biochemical indices will return to normal, in addition to which bone density will improve. And again, from our experience, the lumbar spine improves first, followed by the femoral neck, and then later by the distal radius. But all three sites will show gains of somewhere between 10 and 15% over the 10 to 15 years after parathyroid surgery. Now, as I mentioned, not everybody has parathyroid surgery. And in our study, monitoring patients for over 15 years, we didn't really see very many changes in terms of these indices. Perhaps the serum calcium rose a little bit after year 10, but otherwise these biochemical indices, including urinary calcium, were unchanged. We also observed over the first 10 years of our study, there were no significant changes in bone density at any of these sites, but we also observed over the next 5 years, there was a reduction at the femoral neck and more dramatically at the distal third radius. It is true that we lost a number of patients over this period of time, but still the data do argue that over time, these patients may be at risk for reductions in bone density, particularly if followed over more than 10 years. In fact, 37% of our patients developed one or more indications for surgery during the 15 years of monitoring. We do have pharmacological approaches to the management of hyperparathyroidism in those patients who are not going to have surgery. It may be because they refuse or there are medical contraindications, but there are always patients who have an indication for surgery. We have drugs that will improve bone density, that will reduce the calcium, and combination that will do both. And here is a listing of some of the approaches. The bisphosphonates are used primarily if bone density is low. Cinacalcet, the calcium mimetic, will be used if the serum calcium is high, and the combination if you want to improve both bone density and reduce the serum calcium. This is a table of the effects of these various drugs, and I want to call your attention to denosumab that has recently been studied in this regard. This is an interesting paper in which postmenopausal women with osteoporosis were treated with denosumab. That's in the hatched bars. And these, another group matched of osteoporotic women with hyperparathyroidism were studied. And you can see in the black bars how much better the hyperparathyroid group did with denosumab than the osteoporotic group. So as we think about this, we have two options in asymptomatic hyperparathyroidism. We have surgery and we have a conservative approach. And I think the bulk of evidence is suggesting that the pendulum is swinging more in the direction of surgery. But both options, however, are still important to consider in every patient. So let me conclude. Primary hyperparathyroidism is a common endocrine disorder. Asymptomatic hyperparathyroidism is most often seen in developed countries. Symptomatic hyperparathyroidism and normal calcemic hyperparathyroidism coexist with asymptomatic hypercalcemic disease throughout the world. The relative proportion of these three phenotypes depends on common medical practices and the extent to which vitamin D deficiency is present. Surgery can be recommended even for patients who do not meet surgical guidelines if there are no medical indications. For patients who are not going to have surgery, conservative medical management is appropriate. Pharmacological intervention is generally reserved for those whose serum calcium is high and or whose bone density is low, and surgery is not an option. And finally, long-term conservative management beyond 10 years is advised now with caution based upon the long-term follow-up that we have been able to describe. So this has been a trip through the world of primary hyperparathyroidism. This is a last slide of my home in New York. It's a beautiful day in this picture, and actually today is a beautiful spring day. I know in Chile is becoming fall, but one of these days we'll be able to get together. But I want to thank you very much for your attention.